Okay. So I'm going to talk a bit about the three types of measures we can use. You've heard a bit about this already. We have outcome, process, and balancing measures. I'm going to give you the debut view of our new visit template we've come up for Profile EMR. I know we have some teams who are not using that EMR. We have people on Oscar. It sounds like Dr. Tu has done some quality improvement work already, though, and does have sort of a framework to use. How many teams are on Profile EMR here, just by show of hands? Okay. And Oscar? Paris? Paper? One person. One holdout. Okay. I'll also show you some of our EMR queries that will really automate some of the measurement process. So you're hearing a lot about measurement. You may be thinking, oh, this is going to take so much time. We're really trying to build it so that it's as easy as possible for you to track. Another question, how many people can go back to their clinic right now and just pull out a list of patients with opioid use disorder? Okay. Is it an accurate, up-to-date list? Hands? Okay. Okay. So we'll talk about that, and that really gets to our population of focus. Okay, so in order to measure our improvements, we want to get that as accurate as possible, because if we make improvements, we want to measure the people we're actually seeing. Okay. The example at Ravensong would be that we make improvements, but then I pull the list of patients. A lot of the patients on that list haven't actually been into the clinic for a while, and then some of the patients we're seeing are not on that list. Okay, I'll talk about our key metrics and then just briefly mention the optional measures. And it's not a complete list, so we want you to come up with your own measures as well if you think they'll be important. So, three types of measures. How will we know that our changes resulted in an improvement? That's basically what the measures are answering. The goals in the aim statements really show us our outcome measures. So what are we trying to achieve? Process measures are the more day-to-day things related to the change ideas you're testing. So you want to see that you're actually doing the tests of change. It's good to have an idea, but you want to show that you're actually testing. And then balancing measures. So if you make changes in one part of the system, you're going to get changes in other parts, and hopefully you can expect some of these. Okay, example. Say the team tries to get an LPN to call patients on the day before the prescription is due with sort of a check-in or reminder, hoping to decrease missed doses and increase retention. So our outcome measures, number of missed doses, and hopefully increasing retention on therapy. Process, so seeing how many of those faxes we get from the pharmacy actually end up prompting a phone call to the patient. And then a common balancing measure is just finding out how much time it takes Tamara, our LPN, to complete the work. Okay, so this is, I know it's pretty small, especially from the back, but this is the visit template we've come up to use in Profile EMR. So, even though everybody isn't on the system, you can really get some ideas on how we're going to track our key metrics here. Some of you, especially the RAC and Connections Clinic, might be using the ORT visit form. Lots of good ideas in there, very comprehensive. Turns out probably a bit overwhelming for a lot of our primary care settings, so hasn't been in common use. Probably the best part of it is the prescription creator, where you can see the previous prescription. So we've kept that part intact. We've tried to standardize it, so you'll have a drop-down list. For OAT, you'll choose either methadone, Suboxone, or Arcadian. Put in the start and end date, the daily dose, and then you just hit the Create RX button, and that will create your duplicate that you can print out on your form. So I'm going to make a video tutorial to go through how to use this in more detail, so you'll be able to look at that, show all your clinicians, have them refer back. And so the other important piece here is the treatment course. So really our key metrics, we need to know when people started the first time, approximately, when people have started the most recent time, and when they reach a stable dose. Okay, so then we can figure out how long they've been on treatment or get the OAT duration. And we need that if we want to measure retention on treatment. So there are some other checkboxes, visit checklists, and you can review the video and we can go over that more later. Okay.
Is that live now?
It should be live Monday, is what I'm hearing from the EMR team. I told them I was going to demonstrate it today, so they got it pretty much done for me. And then I said, wait, I'm just going to show a screenshot. I think they still have to figure out which typing template, but you'll be able to find it in the forms if you type OUD visit template. Okay. For teams not on Profile EMR, we can certainly go over how your team might build something like this and try to automate certain parts of your measurement. You know, part of this could be done in Excel, and I think Connections has an Excel spreadsheet that tracks some of these things too. Okay, so how many people have used the QI or queries environment in Profile EMR? Okay, so a handful. I think our goal will be increasing our awareness and knowledge of how to use this. So really, this is an environment. It's a copy of the Profile EMR database. I know it's getting much more technical now than the previous talks. So yeah, it's a copy of the EMR database, and we can really run queries on anything that's been input into the EMR. So we can use that form and the information from the form to pull out a lot of our key metrics. And this is a lot simpler than us tracking manually every prescription. When the clinician makes the prescription, that's it. That's what they've recorded, and then we can pull out the list at the end of the month using a query. Okay, so I'm going to use a standard of naming when we create these queries. So they'll all be titled boost, and then a number, and then an N or a D if it's a numerator or a denominator, and then the measurement name. So that'll be kind of when you're looking at the queries. We should have at least one team member. Oh yeah, so this is just what Create RX will spit out at the end once you click it. And it'll be obviously a duplicate pad if it's Suboxone or Cadian. Okay. So yeah, each team should have at least one member with access to this QI or queries environment. You can email me, that's my email address, to get this set up, and we can talk about getting some basic training on the queries environment, some initial help documents. All right, and then we also have this Excel tool we stole from the HIV Collaborative. It just changed the names, and it'll really allow you to put in your aggregate values for each month, and then we'll automatically create the run chart. This is something like this. Okay. So I touched on this before, but we really need to know who our group of patients are. Okay, so this is our population of focus when we're looking at the measures. We want a list of active clients within our team who have opioid use disorder. Okay, that should be easy to get. It's not most of the time. So this is due to a variety of reasons, you know, incomplete or inaccurate problem lists, patients who don't have the correct point of service or POS or clinic site set in the EMR, and people who are just should be discharged but are still open to us in the EMR. So we want to get a baseline estimate from the EMR, and because of the problem list issue, we thought the best way would be to filter by our point of service. So that's our clinic code, Ravensong. I work at Ravensong, so I chose that. We want active patients. We want to look back 1 year because the data quality really drops off after that. And then anything in the problem list that has the text, you can see OUD, opiate, opioid, methadone, heroin, Suboxone. So I know you're probably thinking there are some caveats to this. There are going to be some where there's a description and it says heroin in there, but it's not actually about heroin use disorder. So that's why it's not perfect, but as Rolando said, the data doesn't have to be perfect. We can work on cleaning it up, but we should get started anyway. Okay, that's just what a query design looks like in the QI environment. Okay, so this is the different clinics on profile EMR, the estimated population of focus. Okay, so I don't know if you can see the numbers from the back. As expected, we have DCHC with the highest, so about 600 with opioid use disorder. You can really see the data quality issue. You know, the next highest one, there's 500 with no primary site set. Okay, so if you see any patient and on the yellow bar at the top, their primary site or PC, you should make sure it's correct. Okay? So that's what I've just said. That's what we call empanelment. Okay? So doing data-driven improvement, we need to do empanelment. Okay? That's basically finding out who our panel of patients is. We just have to make sure they're labeled with our clinic and they have an MRP. Okay, so anytime you see that yellow bar and it has an outdated MRP or an inaccurate point of service, or now it says PC, make sure you have a process for getting that corrected. Okay, on our new OUD visit form, we'll also have just a checkbox where you can add a standardized diagnostic code. We think it's very important to track all our patients with opioid use disorder as one group, so we would like to have this diagnostic code added for everybody. It's as simple as checking that box, and it will be checked already if the problem is already in the diagnostic list. So the first time you open the form, if the box isn't checked, you check it, you're done. Okay, so what about, you know, teams who are not doing the actual OAT prescribing? For example, John Doe, you know, gets his methadone from the private clinic, but it comes to us for primary care. Should he be in our population of focus? Anybody have thoughts on that? I would lean to yes. Okay, you know, if his OUD care is not optimized, I'm going to have a lot of trouble managing the rest of his primary care. So I think we should still be asking, what dose are you on? You know, how long have you been on? Different things like that. And try to get him to get all his services from us if we're able to provide primary care plus methadone in the same place, or OAT in the same place. Okay, driver diagram, that was just introduced. I wanted to show where our key metrics line up on here. Okay, so we have engagement, OAT access or initiation, patients with active OAT, optimal dosing, retention on OAT, and a quality of life score. So you can see the different colors show where these measures are really measuring along the driver diagram. Okay, first one, engagement. I'm just going to go through these fairly quickly and show you the definitions as we have them so far. The definitions will be updated and become more operational as you work through with your teams what's important to you, okay? Especially for the first one, engagement, okay? So how do we measure engagement? We have to find something that is feasible and hopefully comparable between teams, okay? So can we measure just anybody with 2 visits in the last 12 months? Well, I don't think that's that great, because what if they came twice in a week 11 months ago? What about 1 visit in the last year and 1 in the last month? You know, you have to really, with your team, figure out something that you can measure and will be a proxy for engagement to your clinic. This is especially important for those teams who don't do the prescribing, okay, because I think, a lot of your role is keeping the client engaged in their OUD care. Okay, next one would be access. So what percentage or proportion have accessed OAT or oral therapy? Okay, so we can get with the form, if we use it systematically, we can get this easily if we enter the treatment initiation date. So that'd be the first time they ever went on OAT. We ask them, we put in that date, then we just count everybody with a date entered there. So that's simple, and our denominator is the population of focus. So we want this to be really high. We want to make sure at least our goal is, it's ambitious, 19 out of 20 patients have at least tried the oral therapy. Okay, to get baseline data, because we're not using the form, it's a bit harder. Okay, so I had to run a list of all the prescriptions for methadone, Kadian, or Suboxone in the EMR, and then cross-match that with our population of focus to see who actually had a prescription on the EMR. So obviously you're missing some people if they got prescription from outside the data I have in the EMR, or if they had it more than 12 months ago. But this is just showing, at baseline, out of the 600 or so at DCH, 420 had some prescription for OAT in the past 12 months. Okay, now, we know that for most people, OAT should be a long-term therapy, especially at our clinics. If we're in Fraser Health, it may be a different skewing, but if they're coming to our clinics, we probably want them to be on OAT. If they're quite stabilized, then we're maybe thinking about transitioning them to private practice or another primary care home. Okay, so this is simple with the new form. We just look for all those where there's an end date of the prescription in the future, or since the QI environment's only updated monthly for our profile EMR, we just would make sure it's in the future after the date the EMR database was updated. Okay, so some baseline data here. We can see for example, at DCH, this is, or DCHC, you can see just over half had an active OAT prescription out of the number of people with a prescription in the last 12 months. Okay, optimal dosing. This is, again, difficult to do at baseline because Suboxone, people use the form differently. Some people put the daily dose at the top, some people put it in the description. That's what our OUD visit form will standardize, so we'll be able to know what doses people are actually on. So we'll be able to use the form to really get the number of people with at least 60 of methadone or 16 of Suboxone. And we want to exclude the people on Kadian for this because we don't have a well-established optimal dose from the literature.
Often we're titrating to absence of withdrawal symptoms, resolution of problematic cravings, and cessation of illicit opiate use by this, which can happen at a variety of doses, obviously.
Yeah.
You kind of miss some of that. I think what we want to capture is people going into remission with respect to their disorder, rather than the dose that they're on. I don't know if this is, how happy are you with this measure?
I know, yeah, so it's certainly not perfect, and so we have thought about this. I certainly have a few patients that are on lower doses. They've been stable for a while. Why would I push it up, right? But we do know, we want to use the evidence we have and have that guide us. So if people, it's really to say if they have any of that still, we should be looking at pushing them up. But yeah, maybe the goal should not be as high as 95% because maybe 1 in 10 are stable at the lower doses. So you're right. We talk about that example actually on the webinar. Yeah, so if you watch the webinar. Okay, and so baseline data, like I said, due to data quality issues, we can only do it for methadone. And the provincial data Rolando showed with the people at optimal dose, it looks like we're actually doing a bit better in the past year in terms of people on optimal dose. So you have the orange, they're on optimal dose, and then the blue is the people not on optimal dose. And again, DCHC at the left. You know, downtown connections, maybe because it's more new starts that they just haven't got there yet. Okay, retention, we can just use the OAT duration from the OUD visit form. Okay, and we've decided to choose a period of 3 months. So at the end of our collaborative, we want to say, have we improved the number of people who have stayed on therapy for at least 3 months? Baseline data, you can add up end to end all of the prescription data in the EMR. Not perfect because some people, there's overlaps or duplicate prescriptions, but you can get kind of an estimate of how many people have been on therapy the whole year or therapy for just 3 months. Okay, and then this just shows the part of the visit form where we're going to be able to get retention data from. So if you just put the treatment stage, when they first started, the most recent start, and the stable dose date, the OAT duration will be calculated. If you put treatment stage as new start, the OAT initiation date will automatically be set to that day. If you put restart, the most recent OAT start date will be set to the day you made that form. Okay, and this is a baseline data, which is not of great quality because of the issues I mentioned, but you can see you have this long tail to the left where these patients haven't been on the therapy that long. And I expect it's not as many who are new starts, it's more people who have started for a bit and stopped. Okay, and then finally, the quality of life score. So we chose to use the PROMIS instrument. I was struggling figuring out what to call it. Scoring tool, questionnaire, instrument. So it's a 10-question instrument that's in the EMR, and it really touches on a very broad quality of life questions. So functioning, mental health, pain, all the usual things there. Okay, we get a score out of 50, and then we want to show that we can hopefully get an average increase in that score over the time of our collaborative. David.
I'll comment on how validated that is for our population. I've never heard of that quality of life scale.
So I can comment that. So it's the same tool that's been is going to be used as part of the Japanese design project, and they've gone through a number of iterations of looking at which quality of life tools will be best to use for our population, and so we're building off of the work that was done for the academic side. And
Has it been validated?
my understanding is that it's been validated and it's been shown to be effective in our population. I don't know if we have contrary information.
Do you have alternative ones in mind, or?
Just the quality of life. There's an 8-item index that we use before, but there's no great quality of life. And again, the caveat with all quality of life tools is that they take years to usually get a significant change in most of the indexes that are present. So they're not great at the quality improvement measures, generally speaking. You use more as a thing to make sure the quality of life hasn't gone down with your intervention. But you don't expect in most quality of life studies to see a 3, 6, 1-year change. It's 2 and 3 year changes. That's because it's things like the biggest term for it, I think, housing, income.
Yeah, things outside of our scope, yes.
And those things do change with health. They take longer to. So I think the caveat with this going to throw is that, you're using it as a screen to make sure things are not deteriorating.
Yeah.
Don't expect that. You shouldn't set a goal that you're going to improve quality of life in the short term.
Mm-hmm.
3-year, 5-year goal is not going to win the quality of life studies. I think that you're going to make people 50% increase would be exceptional.
Okay, yeah. Yeah, so this is why we're not prescribing that we do these measures exactly, but this is what we've come up with. For the quality of life, we also see this as a main driver of our outcomes specific to opioid use disorder. Okay, so part of the commentary at our working group and in other discussions is that we're focusing only on OAT. Okay, so we want to also be able to back up And maybe it's not the measurement, but it's also a change idea, getting people to back up and do this questionnaire. And then if they do have 10, like a high score on chronic pain, we're dealing with that chronic pain. So it's also an assessment tool. I think that's where it's maybe more useful. All right, so that's just where the form is. You can search for it in the EMR. It's called PROMISE. It should have an score calculating function according to the EMR team. Okay, and these are optional measures. This is just what they'll look like in the Excel reporting tool. If you come up with your own, if you want to make more, we're happy to hear about it, happy to help you design them so they can be accurate and add them to the reporting tool, all of that. All right, so I know that's a lot of technical stuff right before lunch, but I think that's it. And we'll have, the guide to measurement and maybe some video tutorials on how to do this measurement, and then you can email us. And certainly we appreciate all the feedback, and we want to modify our measures and make sure we have the best ones. So